I'm Lindsey Smith, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. Even though elder mistreatment and abuse affects an estimated 1 in 10 older adults in the U.S., experts consider it an overlooked issue compared to other social challenges. We're going to dig into this very troubling topic and learn what the field of geriatric medicine is doing about this and other health-related difficulties facing seniors with Dr. Julia Hiner, Associate Professor at the University of Texas Health Science Center at Houston McGovern Medical School. Dr. Hiner also serves as the Geriatric Medicine Fellowship Program Director and has pioneered the nation's first clinical fellowship focused on elder mistreatment. Geriatrics typically refers to the care of adults aged 65 and older. She holds leadership roles in numerous professional societies, including the American Geriatric Society and Texas Guardianship Society. Thanks so much for joining us today, Dr. Hiner.
Absolutely. Well, thank you guys for having me.
Let's dive in. Can you tell us kind of what got you into medicine in the first place, and then what led you to focus on geriatrics in particular?
Well, medicine in general was probably related to my mom's health concerns. She had cancer when I was growing up. And so, for better or worse, I spent a lot of times in hospitals and healthcare settings. And I loved how it was kind of a 24-hour setting. There was always something happening day or night. And virtue of growing up in Houston with the world's biggest medical center, it truly never slept. So that got me interested. And then as far as older adults, I got interested in taking care of older adults in my fourth year of medical school when I happened into a geriatric medicine rotation. Since then, I've really loved taking care of older adults, so continuing that as my career made a lot of sense.
I liked what you said there about how your mom really inspired you to get into medicine, and then your rotation really kind of shaped how you got into the care of older adults. So tell me, what do you most enjoy about working with older patients?
Well, I love working with older adults because, a lot of people, as they get older, they develop this clarity about like who they are and what they want. And in geriatrics, we always cite the John A. Hartford Foundation because of their age-friendly health systems initiative. And one of those is the 4Ms framework. And the pinnacle question of that is what matters most. And older adults are much better at identifying what really matters. And I appreciate that about them. And so this very special sort of authenticity and wisdom, both it inspires me in what I do as a professional, but personally and maybe selfishly, I feel like it helps give me clarity in my life. I'm better able to align the care that they might want. We work together as a dyad and focus on their priorities. So it's just been very fulfilling personally and professionally.
Yeah, and I think that's such a wonderful perspective that older patients bring such rich life experiences, resilience, the wisdom, and I think it's incredibly meaningful to be a part of their care journey at that point of time. As I mentioned in the intro, you developed a special focus on elder mistreatment. Can you tell us why that area matters so much to you personally and why it should matter to all of us?
Absolutely. Well, like a lot of my career in geriatrics, my interest in elder mistreatment also started off fairly serendipitously. The first and only attending job I've had for the last 7 years at UT Health, the way that job was set up was a good chunk of my time was spent caring for older adults who had experienced or were still experiencing elder mistreatment. And I didn't really know that when I applied for the job. I figured it'd be just a hospital and clinic kind of job, a standard doctor gig. But I quickly realized that this work in elder mistreatment and capacity assessment was a really good fit just for my personality at baseline, but also the aspirations I had for being a clinician. And that's really what has stuck with me is the passion. But I also appreciate how much opportunity there is to do like good for these older adults. We can help them inside and out. Their lives can be made safer, happier, and healthier. I didn't really feel like I was kind of running against immovable objects and feeling stuck. But ultimately, my passion isn't, the end all be all. The reason it really matters for everyone else as well is elder mistreatment is really underdetected. It's vastly underreported. Just some really quick statistics about 1 in 10 older adults who are cognitively healthy, like don't have a dementia process, may experience elder mistreatment. And then if they have any cognitive problems, it rises to about 50% of them. So it's a coin flip. Every adult you meet, if they have dementia, they might be being harmed by someone. And despite these staggering numbers, only about 5 to 10% of those cases are reported. And Adult Protective Services actually did their own internal work and found that only 2% of their cases, maybe even a little less, were made by physicians. So physicians aren't reporting, we're not detecting. So I think the education aspect is really important too. And I guess the last thing I'll say on that is, because this is such a vulnerable population, it comes with such a high risk of death. The risk of death triples after you've experienced elder mistreatment. You're more likely to get hospitalized, show up in an emergency department, things like that. All of this, the associated costs, we all have a part in managing it and preventing it and caring for those who've experienced it. Even pediatricians who might have little patients with grandparents as caregivers.
Right, exactly. And I think your dedication to addressing elder mistreatment just really highlights the crucial and overlooked issue that it is. And this work is so important. I liked what you said there about there's such an opportunity to make a difference here and do good work. And we thank you for that. I want to talk a little bit more about the elder mistreatment and understand a little bit to what you think the main contributing factors are.
So, as I alluded to, cognitive impairment, of course, is a huge concern and a huge risk factor. And that cognitive impairment isn't just limited to dementia, it also includes any mental health concerns, perhaps a traumatic brain injury, a stroke, or even a longstanding intellectual or developmental disorder. With that, if the cognitive impairment is severe enough, they also can have their decision making abilities affected. But on top of that, fortunately, we saw this pretty badly in COVID, but being socially isolated or lonely can have a huge impact. And people like to conflate those two. So just for sake of education, since that's what we all do, social isolation is just the sheer number and quality of the social connections you have, people you can talk to or depend on, or maybe just even be around. But loneliness is more subjective. You can be in a crowded room and feel lonely. You can be married and feel lonely. So those are probably the top two big concerns, but also things like substance abuse, caregiver factors, being physically disabled as well. All of those can impact your risks of being abused, neglected, or exploited.
Thank you so much for sharing all of those contributing factors with us. I want to switch gears slightly and talk about capacity assessment. I know capacity assessment is another main area of interest to you, but can you help our listeners understand what is involved in that and the growing need for it?
Sure can. So, capacity assessment, I think, is something that a lot of people in medicine feel like they're very comfortable with. But when push comes to shove, they really haven't been taught how to perform a capacity assessment in a full sense. So, magically, when we turn 18, we get all these rights but with them responsibilities that just happen by virtue of turning 18. And, it's kind of funny, some older adult wisdom. Uncle Ben in Spider-Man, or Peter Parker's uncle, an older adult, was the one to give that wisdom about with great power comes great responsibility. And the responsibility of all these new privileges is that you have to use them to take care of yourself. And so a reasonable person, when they're making a decision, they might weigh risks, benefits, alternatives to try to figure out what they want to do. But that's not enough. I have small children, and they certainly they have opinions and they can make a decision, but they lack the skills to fully carry it out. And so when someone is incapable of carrying out these steps from planning to execution, they lack both decisional capacity and also executive, or the ability to carry out a decision. And that spans all domains of life, ranging for your food, your clothing, your shelter, your health, and your finances. And if you can't do things adequately in those areas, especially repeatedly, you might be determined to lack capacity. And so that's what I do a bit for my older adults experiencing elder mistreatment. I get a history, I examine their memory and their mood, I talk to people who know them, review records, and make a determination on how safe they are or are not, and if they lack capacity or not.
I love a good Spider-Man reference, as I have little ones as well, so I appreciate that. But to recap for our listeners, capacity assessment evaluates an older adult's ability to understand and make informed decisions, and then also be able to carry out those decisions about their health and daily life. So Thank you so much for sharing that with us. So what are some of the biggest challenges older adults face today, and how is geriatric medicine helping to address them?
That is such a great question. And it's a really hard question to answer. We could have a whole podcast dedicated to that for sure, because ultimately, the world really isn't set up for older adults in general. And this ranges just even zooming out from healthcare, from everything in the way we take care of people and the care that is available to older adults, but more focused on healthcare, since that's an area I'm more comfortable with. We've got issues with insurance coverage, like hearing aids are still not covered by Medicare, but it's like wearing glasses. You have a right to have the ability to hear. Exam rooms are very tiny where wheelchairs and caregivers can't fit with the individual. Appointments are short. And we're not teaching medical students, residents, and fellows how to not overtest and overtreat individuals who may not want that, and so on. Many, many issues. But I think what it all gets back to is that there is really deeply ingrained ageism in our society, including even ageist beliefs held by health professionals, older adults themselves. It's very hard to combat if you don't recognize it. So, shifting slightly to geriatrics, our biggest problem is recruitment. And in my case, I didn't even know geriatrics was a field until fourth year of medical school. And I'd already decided I wanted to be an internist at that point. And thankfully, geriatrics is a branch point from internal medicine. But if I picked a different field, well, I just wouldn't be a geriatrician today. And I often get results that are a mix of, ew, why do you want to take care of older adults? Or, oh, thank God you're doing it, but I certainly couldn't do that. And this is really upsetting to me because I take care of older adults and I have a great time doing it. So we kind of have a big public relations problem, despite having some of the best and most passionate educators in medicine. I know in my division, we're constantly getting awards for teaching and the work we do. We present, we publish, we do all of the things, but we still kind of fly under the radar. So as a program director for geriatric medicine fellowships, I really try to connect with medical students early on and often. And so I can advocate both for the medical students as people, but also to expose them to the joy that is geriatric medicine really early on.
Thank you so much for sharing that. And our audience is largely medical students. And so just wanted to give you a quick opportunity to try to recruit some of them to this field. So what would you say makes someone very successful in geriatric medicine?
Well, I think we are really experts at problem solving and treating each patient as an individual. I like to joke that geriatricians need to rebrand as complexivists because every single patient we take care is complex. They have multiple things going on all at the same time, and the littlest things will tip them from health to less good health. Additionally, people have this idea, which admittedly makes me really frustrated, that, once you've taken care of enough older patients, you're equivalent to geriatrics. But that's equivalent to being like, oh, well, I've taken care of a patient with heart disease or lung disease. I'm also a cardiologist and a pulmonologist. And the approach is completely different. So I definitely think that's an unfair characterization of what we do. We manage multi-complexity as well as making sure that we are taking care of the person in front of us as a unique individual. We need to reimburse more. I think that's a problem for geriatric medicine and drives people away. They see the reimbursement is not on par with many other physicians, and they say, wow, I've got student loans. This isn't going to work, even if in every other way it would be a good fit. So I think there's a lot of PR problems. I think we need to require the rotation in medical school and make it longer than 1 week.
Yes, absolutely. And I like your idea of the rebrand and that you're taking such a personalized approach to these complex patient challenges that you do have. This kind of brings me into your last comment there about making it a required course. We recently had a Raise the Line guest suggest that medical schools should require courses in geriatrics, similar to how they do in pediatrics. What do you think of that idea?
I mean, you could probably guess this, but I love that idea. And, at my medical school, at McGovern Medical School, where I teach, we do have 1 week of geriatrics. And while I'm really grateful for the time we have, it isn't nearly enough to take care of older adults. No matter what field you practice in, you are going to take care of patients who are older, probably a large proportion of your panel. And again, it's not as simple as taking care of a few older adults to learn all the skills. Once you've met one older adult, you've met one older adult. Each and every one is different. The research, although growing, isn't the best. And so we do a lot of figuring out in the moment based on available evidence and patient preference what we can do to maximize their quality of life and their goals. And so I always like to tell people, once you go to a geriatrician, either as a student or a patient, you never want to go back because you realize the approach is very different. But there's only 7,000, 8,000 geriatricians out there in the whole United States, and clearly many more older adults than that. So our patient panels and wait times are huge because there is a huge demand for our specialized skills. But again, Medicare drives reimbursement, and so people don't seek out geriatrics as a specialty due to that and just not knowing about it in time in medical school.
Yes, agree entirely. And I think adding a course in geriatrics would be beneficial for all medical students. I'm glad to hear that at your medical school, you guys are doing this. And kind of staying in the same realm of education, this leads me kind of to my next question. So as you know, at Osmosis, we are a education platform, teaching company, and we love to fill knowledge gaps. Is there a topic that you think Osmosis should make a video on to fill that gap that is of particular interest or concern to you?
Yeah, I would definitely have to say elder mistreatment. As an educator, part of my research is in the domain of how and if we are educating medical students and geriatric medicine fellows in particular, but really health professionals at large about elder mistreatment and its intersections with capacity. And by and far away, I have found consistently that students, learners, trainees do not get this information. And if they do, it's maybe one presentation over the course of, 7, 8 years of their education. So it's very easy to miss. It's very easy to forget, especially if you don't know that you don't know. And we want to move people from an unknown to at least unknown, because that's where the learning can start. And, I always think it's funny because if someone with cognitive impairment has a 50% chance of experiencing elder mistreatment, and clinicians aren't recognizing it and aren't being taught to recognize it, it's forgetting to teach medical students that Y chromosomes exist and only teaching about X. We're missing half of what we need to be seeing. So it's very important. So I'd love it if y'all had more training on that.
Elder mistreatment is a great topic to pass along to our content team for future considerations, and we will certainly do that. If it does get created, you will be the first to know. So thank you so much for that suggestion. We do have many students and early career health professionals in our audience today, and I wanted to ask you what your advice to them about meeting the challenges of this moment are and approaching their career in healthcare.
Well, when they survey physicians, and remember to include geriatricians, we're often left out of these surveys, but when they do survey physicians, including geriatricians, geriatric medicine doctors routinely top the charts in career satisfaction and work-life balance. And that, I think, says so much because these days, a lot of physicians and medical students and people anywhere along their career trajectory, they feel burnt out or have moral injury or really whatever you want to call it. But all of us, to some extent, feel tired, overworked, and stressed. There's so many administrative tasks. The documentation is a mountain that you feel like you can never summit. And geriatricians, of course, we're not immune to that, but we're human. We have all the same challenges. But the work that we do is so fulfilling and moves at a slower pace, the pace of our older adult patients, that we actually have space to create the humanistic side of medicine, and it can take root and grow in our patients, but also in us and the relationships we have. I think that's largely because in addition to having a little bit more time with our patients and longer appointments, we also guide people through their older adult years and sometimes even their final years as they continue to make and find their meaning in life. And as a consequence of that, we get to bear witness to the happy, sad, and even bittersweet moments of life as trusted partners along the way. And all while doing that as clinicians, we get to take that same knowledge and share with learners at all stages about why we do what we do in geriatrics, and ultimately hope that they see the same joy and fulfillment that I do every day in my career. And so The best advice I can give is what I experienced in fourth year of medical school in geriatrics. I found I was working 80-hour weeks, just like the interns next to me. And even though I was tired because I'm human, I was happy. I went home happy every single day. It didn't matter, what storms we had to weather. Ultimately, the healthcare and medical landscape is changing. And so we're going to have new storms to weather. So we need to find fields that make us happy, ones where we can care about the medical situations, of course, like we're trained, but also these social determinants of health and everything. And even though it's been 11 years since I was that bright-eyed medical student in fourth year, I still don't feel burnt out. I feel excited. I tell my husband I struggle to know which day to take his paid time off because I don't want to miss what's going on at work. And so I'd encourage medical students and other young professionals to find a field that they want to do for the long hours and hard times, because those will be present. Find the people that they want to work with, but ultimately see what types of patients bring you joy and who features in the stories that you go home and you tell your family about. And if you find that it keeps circling around older adults, I encourage you to take the leap into geriatrics, because honestly, you won't regret it once you're here.
Career and work-life balance is so important to all health professionals and really everyone in the world. And for our early career health professionals out there, you heard it here first. Geriatric medicine is definitely worth checking out, and we hope you do. I liked what you said there about finding that joy. And I think it's so clear your passion shines through when you're speaking about it, that you truly love what you do.
Thank you so much.
Before we wrap up this episode, I wanted to give you the opportunity, if there's anything that we haven't maybe covered that we should cover.
Well, I think probably the only other thing I'd say is that if you have any interest in geriatrics, or just have an older adult who is influential in your life or your career choices into medicine in any way, reach out to geriatricians, whether that's at the institution you're at or just national organizations like the American Geriatric Society. Geriatricians love teaching, and we love mentoring and advocating for our learners. So even if you're not finding geriatricians or good mentors at your institution, please know there are a whole 7,000, 8,000 of us across the country that are more than happy to take you under wing, do research, expose you to clinical opportunities, even at a distance. So if you have interest, don't sit on that. Get to know it. If nothing else, it'll inform however your career trajectory goes. It'll inform the care of the older adults you encounter, no matter your specialty.
So to recap there, if you have any interest in geriatrics, please do reach out to the over 7,000 out there and see if it's for you. It could be a good fit. Thank you so much, Dr. Hiner, for being with us today. It is so clear that geriatrics is a wonderful fit for you, and we thank you so much for being on the podcast today.
Thank you for having me.
Elder mistreatment may be hidden in plain sight, but thanks to champions like Dr. Hiner, it's finally getting the attention it deserves. From pioneering clinical training to advocating in courtrooms, Dr. Hiner is helping rewrite the narrative on aging with dignity and protection. Thanks for joining us, and remember, raising awareness is the first step towards change. I'm Lindsey Smith. Remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelines podcast.